I'm here with Mitch Weikert, a member of the ASCRS Refractive Clinical Committee. Mitch, this is, I'm a geeky guy to start out with. I'm an optics guy, so this is right up my alley. The truth is that most of the IOL calculation formulas that we use work pretty well for average length eyes. Mm-hmm. But there are problems with eyes that are very short and very long. Before we get to what those problems are or what you recommend, can I get you to define what short is and what long is?
Sure, Josh. Yeah, these eyes are more difficult to deal with, and with the expectations that our patients have these days, it's really on us to be comfortable with the formulas and know which ones are better in which situations. And the eyes aren't really that uncommon. We see long eyes greater than 26 millimeters in up to 16% of our patients, and short eyes less than 22 millimeters in up to 7% of our patients.
And what are let's break this down. Let's deal with long eyes first, since they're more common. What is the source of the problem with long eyes? Why do we have problems with it?
Well, with any formulas, if you look at the main sources of error, probably the biggest one is the effective lens position, knowing where that lens will sit in the eye after cataract surgery. The second main one, when we're trying to decide how these formulas perform, is actually the manifest refraction, because if we don't have a good postoperative manifest refraction, we really don't know how well we're doing. And the third is axial length. So within those three, we're trying to, for long eyes or short eyes, figure out where are the problems. Well, with long eyes, effective lens position isn't really as big a deal because we're talking about lower IOL powers. So if you're off a little bit and have a little bit of an error in effective lens position, that's not going to manifest to a big refractive error because the IOL powers are lower. So then it kind of has us steers us towards looking at axial length. And these days we use optical biometry for most of our axial lengths, and it performs really well. And it is significantly more accurate than ultrasound biometry, but there are still problems built into how we do that. For instance, we have these devices that can use interferometry to measure all the segments of the eye, the corneal thickness, the aqueous depth, the lens thickness, the vitreous cavity depth. But when it comes time to compute the actual displayed axial length, these devices actually use a single index of refraction that's kind of an average to represent an entire eye. And then they give you one axial length that kind of is constructed from that value, which ignores maybe changing relationships between the different segments of the eye. And then when these devices, or when they first came out, like the Master 500, when they were trying to figure out what axial length are we going to display, how well does this device measure this, they actually used regression fits to make that match ultrasound. And the eyes in that fit that were short or long were less represented, as you might expect, than eyes in average axial lengths. And so that's another source of error. So we've looked at studies, as well as other people, comparing the displayed versus the actual segmented axial length when you look at individual refractive indices for the different segments, and found there is a significant difference. And for short eyes and long eyes, we start to see a bigger difference as we get towards more extremes of axial length. And so when we look at prediction errors, we are publishing a paper that should be in press very soon, that if you factor that into your calculations, you see lower prediction errors when you do segment the axial length versus using that average axial length.
But while we're talking about long eyes, if axial length were if biometry were the main source of error with long eyes, and all of the formulas are being fed the same biometry, then one would expect all of the formulas would perform the same with long eyes, but that's not true.
Well, most of the formulas we use today are still kind of have the same fundamental principles. They're based on geometric optics, but they're not all exactly the same. And say the Barrett, which actually performs probably very well on average, it's one of our better formulas.
The Barrett Universal 2.
Yeah, has built-in compensations for long eyes and short eyes. Still not perfect, but does a pretty good job overall. So.
Yeah. Now let's talk about short eyes. Then I want to kind of circle back to the whole sort of game plan thing.
Okay.
Okay. Short eyes, please.
So short eyes are a different animal, but they are going to be more sensitive now to errors in effective lens position because we're dealing with high IOL powers. So little differences in effective lens position can produce greater differences in prediction errors and actual refractive errors after surgery. And a lot of our formulas may not do as great a job of kind of changing the relationship between the aqueous depth or the anterior chamber depth and the lens thickness as we get to shorter and shorter and shorter eyes. So we start to see errors there. And as I said earlier, short eyes also suffer from that same problem with the optical biometry axial length that we get that's displayed on our devices.
So what do I do?
Well, for long eyes, there's a couple different approaches. Doug Koch and Lee Wong kind of recognized that axial length issue and did a regression fit and came up with formulas to adjust the axial length to plug into some of our known formulas. So if you take an adjusted axial length and plug it into a Holiday 1 formula, it does very well. It tends to give you a little bit results on the slightly more myopic side, but it does well, as does the Barrett. On shorter eyes, we studied all the formulas out there, looking at 7 different formulas, including, say, the newer ones like the Hill RBF. And right now, they're all fairly equivocal and equal. There was a very nice study done by Jack Kane a few years ago where they looked at 3,000 eyes, and they divided them into short, medium, long, and long eyes. So when you look at the short eyes and the long eyes, the formulas that did very well in that study were, in short eyes, the Hill RBF, the Holiday 1, and actually the Lattice Super formula, which combines several formulas that are geometric optics based and just varies which formula it chooses versus axial length. So at short eyes, it uses the Holiday 1. So really, the Hill RBF and the Holiday 1. For long eyes, it was the Hill RBF and the SRKT, which isn't surprising. We know that does pretty well for long eyes. But and again, we also have an adjusted version for the SRKT that performs well. When you look at all axial lengths for that study, the 3,000 eyes, the Barrett actually did very well across all axial lengths.
So let me ask you a real sort of practice question and avoiding system error question. Okay. So when I do biometry and the calculation's done sort of in system, and then I get a printout and it tells me what lenses to do. That's what I do, obviously, for average length eyes. The risk for me and for most people in clinical practice with saying, well, I'm going to use this formula for very long eyes is that the information has to be physically typed into a website, and there's the risk of entry error. At what axial length, or for what sort of patient is that risk worth it to say, okay, now I'm going to do a Hill RBF calculation, I'm going to do a Barrett calculation at the risk of typing something in wrong? Of course, I check things 30,000 times, but there's still that risk.
Yeah. Well, we're lucky that a lot of these formulas are built into certain devices, like the LensStar has the Hill RBF built into it, as well as the Barrett. But I do think on these long, extremely long eyes and these very short eyes, I think it is worth the effort to take the time to manually enter this information on the various websites that are out there available to us. And I think if you adequately train your technicians, really make them understand how critical it is, and then allow them to give you that information to where you can kind of verify it yourself. They can print out the website calculations where you can see the data that they entered. You can quickly go through that and make sure that it's okay. Actually, our technicians have a stamp that they put on the calculation sheet when they adjust the axial length, and they'll write the adjusted axial length in there. We'll have the original sheet so we can go back and make sure that those numbers are correct, and that way we have a good backup plan to know. Can I give you one other caveat?
Please.
One thing you have to be careful for is if you do use, say, these adjusted axial lengths in long eyes, and you plug in the new axial length into your biometer and get your printout of calculations, if you have several formulas on a sheet, like we do, we have the Holiday 1, we have the Barrett, and we have the Hill RBF as our standard printout. Well, if we put in an adjusted axial length for the Holiday 1 and look at that calculation, it's going to be invalid for the Barrett and the Hill. So you got to be very careful about that.
Yeah, no, that's a great point. There's still a lot of manual work with it.
Yes.
Mitch, I want to thank you very much. Obviously, this is a very, very practical topic. We want to please our patients. We really want to do cataract surgery only once per eye. So I want to thank you very much for your generosity of your time with us today.
Great. Thanks, Josh.